Hey guys, welcome to the podcast this week. Listen, super excited for the guests that we have on. I've really been wanting to have these two on the podcast for quite some time, and it just hasn't worked out. But this week we made it happen, and I've got my good friend Scott Howell, Jerry Smith. Welcome to the podcast, guys.
Thank you. Thanks for having us.
So I want to start. We're going to get into some really cool, controversial topics around women's health and things like that. But I really want to start with just giving the audience a little bit of a background. So, Jerry, let's start with you. I've known you the longest. We've known each other for 15 years, probably.
About 15 years, probably.
And
where the bodies are buried.
Absolutely.
That's right. Tell us a little bit about you, Jerry. You're a co-founder of Optimize You. How you kind of got into this space, your background, why you are interested in hormones and longevity.
Like you, I'm a PA, and we're kind of like the Swiss Army knives of medicine, it seems to be. And so I worked in hospital medicine for a bit, and then I worked in orthopedic spine surgery, and you were in the ortho group with us. And I had an interest in hormones because I was doing the osteoporosis track a lot, and I would see these women, they need estradiol, but what they get is bisphosphonate, or they get rank ligand drug. And then these drugs, I don't know if you know about rank ligand drugs, you probably do, but they're like $1,500 a pop, But if you look at the studies, estradiol crushes them. But estradiol is like what, $50?
Right.
$50. And so from that, I met some other people, Josh Hudson, my business partner and friend, and we just kind of came together and went, you know what, we could do something that would help people do it for cash, bypass the insurance system, because it's kind of like a legal pyramid scheme. And now we have 36 clinics nationwide, and you operate a bunch of them for us, and you're doing better than we are at a lot of things. So it's a really interesting time to be in this market, and we're really fortunate. But I truly think we're doing good.
Yeah,
community. That's who we are. We're trying to be not necessarily the McDonald's of hormones, but to set a standard, so to speak.
Yeah. Well, and I'll say this really quick, and then go to you, Scott, because I think this actually applies to both of you. We actually had a dinner meeting last night with a rep, and he's started to hear a little bit more about Optimize You, not just here in Chattanooga, but a few other clinics. And he said, "Man, one of the things I'm most impressed about is the reputation around how you guys do medicine, right?" And I just say that because I think what most people may not realize about Optimize You is the role that you both play in that, because I think that's what sets a place apart, where you're a concierge practice. You've kind of got that reputation. We have to it's going uphill against that mentality where everything's a sell and not doing things ethical, right? And that's something that you guys pour your life into, on the training, the education, the malpractice, the research.
Well, there's bad actors in all areas of medicine. I mean, you could look at examples of like traditional medical clinics that have scammed Medicare, Medicaid. Look at those ophthalmologists in Florida that were like millions of dollars in the Medicare. So I think just because we're concierge doesn't instantly equate to it's only for profit.
Right.
I mean, the mission statement is still patient-centered and patient-forward, and you could call it joint decision-making or whatever you want to call it, but we still put the patient first regardless of the profit.
That's right.
I think it makes hormone treatments accessible to the masses that wouldn't otherwise be able to afford them. And I like that, because it allows people that previously would not have the resources to do things, they can afford hormone therapy.
There's still a fear out there, though. There's still a fear of, well, I have insurance, and if I don't use it, does that make something wrong with this practice? There's a fear coming from a patient's perspective, too. Maybe it's not a fear. Maybe it's just a misunderstanding.
I tell people all the time, I don't know what you tell people about this, but, okay, so we all have car insurance, right? Home insurance. Does your car insurance that you have to have buy you tires? Does it pay for your gas?
Right.
No. And so if you want premium things in your life, you can't let your health insurance be the only default thing that gets that to you. It's not necessarily the best care at that moment, just because Anthem says it is.
Right.
Yes. And so I think if COVID did anything good, it probably shed light onto the fact that maybe my family doctor isn't informed about every single thing that I need him to be informed about. And maybe Aetna doesn't really care if I'm sick or not, and they just need me to take this vaccine for whatever reason. Don't get political about that. I'll just say, concierge medicine brings something to the table that's not just traditional, like reactive sick care medicine.
That's right. Yeah.
And the guidelines aren't always correct. The menopause guideline for the Endocrine Society was just retired due to outdated material. Right. So, and then that will get us into the women's hormones really quickly.
Right.
And I think I've told everyone in Optimize You, I really went into science to discern fact from fiction. And that whole exercise in having a bias running into a study and then your bias is overturned, I had to change my belief based on evidence. It's the hardest thing I ever did in my life to suck that up. But now it's easier. And I look at the highest quality evidence to guide practice because guidelines are wrong.
Right.
Look at all the guidelines that put out all the stuff about estrogen and breast cancer.
Wait, pause for a second. I think I hogged the intro to this. Why don't you tell them who you are?
Thank you. I was going to say
because you're talking and people don't know who you are yet.
Yeah. So, from an education standpoint around Optimize You, I think, again, one of the things that sets us apart is I don't know of many other organizations, clinics who have somebody like you, PhD, research focus. So give us a little background to who you are and what you do at Optimize You and just for the bigger picture of hormones.
Well, obviously, the last doctoral degree I received was a PhD. And I focused on how do we measure disease? How do we measure mortality? How do we measure morbidity? And that led me to specialize in epidemiology so I could interpret studies. And one of the biggest things that I found is that even a lot of my PhD students at that time, after I graduated, I served as a dissertation chair. I taught a lot of classes. Even my PhD students could not gauge the credibility of their sources of information. And so one of the reasons why I'm paranoid and why I always check the information is just because someone says it doesn't mean it's true. Look at all the stuff with the Women's Health Initiative.
Yeah.
And
write that down.
We can go through that point by point, but that was a disaster. The results pretty much across the board for the adverse health outcomes were non-statistically significant, but they were interpreted as if they were meaningful. And that led all these societies, ACOG, NAMS, and the Endocrine Society, to change their practice. And it went for the lowest dose for the shortest amount of time. But is that risk that was reported really true? Well, if you look at the 20-year follow-ups of the Women's Health Initiative, the incidence of breast cancer went down with the women that stayed on therapy.
Right. Almost 23%, right?
And I wholeheartedly kick back on the notion that 17-beta estradiol is a carcinogen. It's an endogenous ligand in the body. Men make it too. And if they classify estradiol, which they did on bench work, and with bench work, what I'm talking about is in vitro, things don't always happen the same as in vivo in a live organism. So just because you do it and with bench work only means proof of concept. It doesn't mean that's exactly what happens in the body. And so where are the highest estradiol levels? When does that occur in a woman's life?
Pregnancy.
Well, that's an exception, but just without pregnancy, I would say reproductive age women.
Yeah.
Okay. They have the lowest risk of breast cancer. It's like 1 in 238 up to age 35, I believe. With every decade, there's an increased risk of breast cancer. Up until you get into around 60 to 70, and it's 1 in every 7 women.
You mean what? When estradiol levels at their lowest?
Yes, not when they're the highest.
Yeah.
So if estrogen causes breast cancer, wouldn't we expect that in the opposite way?
Yeah, it's good.
It's diametrically opposed.
Yeah.
And there's so much, what I believe, fraud, because what industry benefited from the Women's Health Initiative?
We're going to get a letter about
This is great. That's why we call it
somebody's
Rebellion
gonna
Health,
send us
guys.
an Instagram.
Yeah, that's why I invited you both on.
Well, think about it.
Yeah.
What industry would benefit from that?
Pharmaceutical.
companies that make aromatase inhibitors, tamoxifen, the suppressive therapy, those.
Osteoporosis medications, cardiovascular medications.
What's the trickle down effect?
All of them,
All of it.
Yeah.
right?
What's the trickle down effect?
Yeah, yeah.
A lot of drugs to be developed for that.
There was a paper, and I like to talk about it. I can't remember the authors, but it was published, several years after the Women's Health Initiative. But they estimated that in a 10-year period after those results were published, over 90,000 women died because of estrogen avoidance. They were being taken off therapy, dropped off therapy, and even if they were symptomatic, they couldn't get treatment at that time. And so now we're this many years later, and all that stuff's overturned, but yet oncology literature still drives, and still, earlier this week, saw a paper that was published. And in their introduction, they talk about the Women's Health Initiative, and they're recapitulating that information over and over again.
Yeah.
Well, the issue with estradiol as a carcinogen, if we use the same metric that they used, wouldn't testosterone be considered a carcinogen?
Yeah.
But it's not.
Right.
And so that's where a lot of
you could argue maybe that testosterone, to a much lesser degree, compared to estrogen, around prostate cancer in men, right, has been kind of, you could put it maybe in that same boat where the myth, and I think there's a lot clearer evidence, and it wasn't as a big of a movement that estrogen causes breast cancer, testosterone causes prostate cancer.
Sure.
But I think that to your point, both of those are endogenous, ligands. Let's walk back, right? I've got a lot of questions on breast cancer, and we'll get to that. Walk us back, either one of you. Let's go back historical perspective, right? Because you said at one point that WHI was kind of that turning point, So take us back to when estradiol, progesterone were, started as far as from a hormone replacement therapy. What was the data that led up to the WHI? What was the overall general consensus, if you will, within medicine at the time? And then we'll go into the WHI a little deeper.
Sure. Scott, you did it first.
The general consensus before the Women's Health Initiative was that estrogen was protective. And so that was pretty much recommended across the board, oral estradiol, systemic therapy. But it is historically been that progesterone or some progestin has been coupled with estrogen. If we take it back, the first approval in the United States for an estrogen product by the FDA was in 1946 or 47. That was conjugated equine estrogen. And so what did we do with men? We isolated the testicular substance.
Right.
And it was named testosterone. That's the main hormone in the gonads of men.
Tell us the part where they had horses peeing in troughs to collect this urine.
Yeah.
People don't know.
Well,
That's
there was
sexy.
Don't you like that?
yes, and so eventually they started isolating conjugated equine estrogen, and I guess since they invested that much money, they wanted to take it to market. But instead of doing the right thing, isolating the natural ligand in women, it started with horse estrogen at that time.
Which is not estradiol.
Right.
There's 10 isoforms that are not native to human metabolism. And so we don't know what the long-term effects of that are. We do know that conjugated equine estrogen is more potent. And it was implicated for the plaque ruptures in the first 18 months of the Women's Health Initiative. Now, if you consider those rates of plaque rupture and compare that to population levels, they're probably comparable. And it's one of the things, even with the Women's Health Initiative, it appears, based on the termination of the trial, it was, well, number one, I have a chapter in a book that I'm running. It's called Designed to Fail. We had a lead researcher, Rousseau, which
We're definitely getting letters.
You are definitely getting something.
I love it.
Sorry in advance.
Keep going. No, it's great.
It tracked me.
Yeah.
I lost my...
Rousseau.
My name is Matt Hughes.
Yeah.
If you want to send me a letter.
In your book, Designed to Fail,
Well, think about this. This is a cardiologist, right? Over one of our national institutes, the National Heart and Lung and Blood Institute. Okay, if you design a trial for primary prevention, When should that start in women that are menopausal? You would
In
wait.
perimenopause?
You would start recruiting in perimenopause, and then when they have 12 months since the last menstrual period, you would assign them into an arm, and it would be staggered. Over 66% of women in the Women's Health Initiative were more than 10 years past menopause.
Right.
That is not a primary prevention study, but yet it was touted to be.
It's like taking pregnancy information from somebody who just gave birth to who gave birth to 10 years ago.
Yeah.
Like let's take and study your pregnancy, but the baby's 10.
Right.
Right.
Well, okay. Please tell me how factual said information could possibly be.
Well, it has to be designed to measure, and so you'd have to follow the natural history of disease. Well, apparently, with the termination of the trials, I forget exactly what the time point was, but that meant that there was women that had breast cancer in the beginning when they were recruited. And so when I filed the Freedom of Information Act request, it was approved, but then I was blackballed because they wanted me to file a full research proposal to actually access the data when I had an approved Freedom of Information Act request. I didn't want what was in the data repository. I wanted all the raw data that they collected to see if there was anything biased in the beginning for selection. We know now that it is not a primary prevention trial, and it wasn't designed for that.
Right.
There was a lot of, I don't want to say collusion, but there was a lot of interaction. Let me back this up. When you file a research protocol and you receive funding for it, that has to be registered. And that means that you can only analyze exactly what you have in that protocol. You can't do exploratory analysis until the first protocol is done, and then you could do stuff after that. And so the whole design, if it wasn't for primary prevention, what was it for? Well, there's published literature with interviews of Rousseau and the discussion that happened there. None of the primary researchers had a hand in writing that write-up. It was Rousseau and pharmaceutical executives that wrote that write-up.
Wow.
They gave an hour to the primary investigators to make any edits. Presented it, here's what it is, and they're reading through it. It would take an hour to read through it.
Yeah.
So none of them got to really put or change stuff. There was one or two lines that was changed, but it went immediately to press. And Rousseau scheduled a press release with the media, and point blank, he said something about changing a paradigm in medicine, and he made it a negative. It was a negative in that press release, like that we should not use hormone therapy for primary prevention.
Wait, so you're saying that people that set these studies up are biased?
Oh, 100%.
No way.
Well, that's why it was designed to fail. There was other motives outside of women's health. And think about all the millions and millions of dollars that was wasted on that hormone trial when it never should have been stopped.
Yeah, say
They
that
should have
again.
let it rode out.
This is a taxpayer-funded situation. We paid for this.
Yeah.
It's terrifying from a woman's perspective. I mean, all I know from a patient's perspective is you go in, I can't know everything. There's no way I could know what you know, Scott. Let's just be honest, on a regular day.
There's no way anyone does.
That's what I'm saying. However, and I mean that as a compliment. However, from a patient's perspective, if something like that traumatizing is happening to me, all I know to do is just listen to what I know as the expert. And so if the expert says, no hormones for you, no, you
Who's
must
the
take
expert?
this
Who's the
my
expert?
doctor.
Right.
Whoever
Right.
that
OB,
may be.
PCP.
Whichever one sent me wherever.
Right.
Because number one, I'm not in a state of mind to be able to go, okay, let me try to think this through. I'm just thinking, dear God, don't let me die. Dear God, do not let me die. And so as I'm going through this from a female's perspective, from a patient's perspective, I'm just going to take everything you say and go, or the doctor says, and just go with it. I mean, am I losing my hair? Am I doing that? Whatever. Just let me be alive for my babies and my family. That's my mindset. So for that not to be the forethought of the people running these studies, it's terrifying.
There's a morality issue.
That's terrifying.
I think it was a major mistake to allow anyone that was biased against hormone therapy before to actually lead that study. Just because if you have bias, you're going to be biased in everything that you do.
And he clearly had bias.
Oh, 100%.
Where's the ethics committee on this?
Yeah.
I mean,
Well,
is that not
I think the Office of Research Integrity should investigate the Women's Health Initiative because I haven't gained any traction. I was thinking about trying to refile again.
Pause.
To
RFK.
force him.
RFK, if you're listening to this, bro, call me. Yeah, help us out. You know?
Seriously.
Seriously.
I really do believe that his actions led primary care, different physicians to drop people off therapy, and it caused harm. You can't tell me it didn't cause harm because when you go off therapy, you lose the benefits of therapy. But even beyond that, we tested the wrong hormones. We didn't test the natural ligand, 17-beta estradiol, which is the safest of the estrogens on the market, period. We didn't test micronized progesterone. But estrase and prometrium have been on the market, FDA approved for quite a while. So that's some. I have tons other critiques of the Women's Health Initiative, but if you have bias going into research, it will end in disaster.
Yeah.
And there was very little benefit, I believe, that came out of the Women's Health Initiative. There was a lot of test paper.
Very little benefit.
Think of the trickle down, not just the direct effect of women dying. Okay. So you go to your OBGYN and that's your guru at that moment. And they have a negative spin on it because of the WHI. And then they give you this confirmational bias of the first information you ever got about at the time you needed hormones the worst, or they're bad. So what do? You tell your daughter, you tell your sister, you tell your aunt. This trickles down multi-generations even from confirmational bias. So there should be an ethics review of everyone at play.
I believe so.
In general.
Yeah.
Well, I have a question about you guys' thoughts around, we're saying, like, I will go to my OBGYN and they would give me this information. Give me your thoughts around, is this something that it came from the education that they received? Like the information they're giving, they're not going, let's see if we can kill Mandy. They're saying, this is what I know.
Nor are they reading the paper.
Yes.
So pause
This
there.
is what I know.
Wait a minute.
So tell me what you think about that.
Before we go down this rabbit hole, let's just say this out loud. We are in no way dogging out
That's
every
what I'm asking.
OBGYN or
Right.
PCP on the planet because God love you. You've got a million other things to do, and hormones are one thing inside that spectrum.
Right.
And who could ever spend the time and resources that we have to go learn the way we have and really tear through the data when you're not really trained to even do that? How much data collection preparation, how much study information do physicians, MDs, DOs, NPs, PAs, pick something?
Yeah.
How much training do we receive on how to tear a study apart from a statistic standpoint? I remember I got like a few weeks.
Yeah.
If that.
Maybe a semester.
Right.
If you're lucky.
At best.
Yeah.
Right. So you need this kind of person
Yeah.
to tear this down for us because I think most physicians are in the same boat that most of us are in.
Right. And I think,
and that's where I'm going with that.
yeah. And I think to your point and to Jerry's, most people are following guidelines.
Yes.
That's right.
And that we can talk about that.
The
but
guidelines exist for a reason.
The
there's
guidelines
that
exist.
keeps everybody in the same left and right
Yeah.
lanes of good and bad, right?
Yeah.
And
so
there's so many conflicts of interest with guidelines. I was taught any primary study that I used to reference any of my work needed to have no conflicts of interest in it. And if I did, I needed to critique those conflicts of interest. Well, if you look at any of these organizations, they receive funding. A lot of them receive funding for their accreditation departments. They can declare that and do it. But the influence of pharmaceutical industry is big. So anytime that there's a conflict of interest, that is a lower tier of evidence for me at that time. But when do we move off from using a threshold of statistical significance to make clinical decisions about risk? That's where the Women's Health Initiative failed. You can, if it doesn't meet statistical significance, then what other metric are we going to use? We're just going to imagine it's going to be a certain way.
Opinion gets thrown in.
And so if you even think about those rates in absolute terms, they fall, all the adverse health outcomes in the Women's Health Initiative fell into the World Health Organization categories of rare or extremely rare. That's less than 1 per 10,000 women per year, or less than 10 per 10,000 women per year. And if you do the math with that, that is a very small percentage.
Yeah.
So why was it even promoted to even state anything remotely that estrogen causes breast cancer? Because even conjugated equine estrogen doesn't.
Right.
It drops the incidence down over time. We see that with the 20-year follow-up.
That's ravenous this morning. About
Dude, he's ready. Yeah.
All right, so back to Mandy's point. What we were saying was, how could it be possible that your OBGYN or your PCP could have the resources and time to know everything there is to know about every disease process ever and be an absolute expert every single time without consulting anyone at that moment? Doesn't happen, right? But the other interesting fact is, and I read this out of a study from, I think it was 15. You'll help me here. 60% of family docs. Now, I'm going to bet that it's very similar in other subspecialties that are kind of like primary care, OBGYN. 60% get all their continuing medical education. And for those of you non-medical people to know, we, the collective medical we, doctors, mid-levels, we all have to have a set number of hours every year, every 2 years, however you want to look at it, to continue our licensing. You have to have continued education credits. 60% of family doctors get their CME from drug reps. So think about that for a second. Right. So the drug rep comes around, brings you some material. You can be tested on it. There can be a little quiz. Okay. You can talk about category 1 or category 2 here if you want to get into that, but they get a lot of their CME from drug reps. Pays for that.
Right.
Who's telling them the information, right? So I have a problem with that. I have a big problem with that. So to answer to go back to your statement about why did my OBGYN tell me X? Maybe they're just going off what the drug rep says that the company told them to say about the WHI.
Yeah.
Right? Who paid for the WHI? The taxpayers. But who set it up?
Yeah.
All right.
So let's stay focused on the estradiol. You've mentioned it multiple times about conjugated equine estrogen versus estradiol, right?
Yes.
Go into a little bit. Not you. I think you've explained the difference there well enough. But let's talk about formulations, right? Oral, transdermal. Why? Again, I think of guidelines, and I think of what we face in the clinic. Of my doctor said you should not take oral estrogen. Okay,
right.
How help the listeners understand where that comes from, what the truth is, and what your preference in general would be.
Well, as a consequence of the Women's Health Initiative, there was a trend for ACOG, NAMS, all the other groups, when they write the guidelines, to recommend the lowest dose for the shortest amount of time, and often recommend transdermal therapy if that person had any risk factors for breast cancer, or if they had a high risk for cardiovascular disease. Well, it's very problematic with that, because if you use transdermal, a lot of times you're maintaining a deficiency. Now, in women, they experience estrogen deficiency when estradiol levels drop below 50 picograms per milliliter. But really, even that's not enough. I mean, we definitely don't want to maintain a deficiency on treatment. But that's really what has happened to a lot of women that have been on transdermal therapy, that we're maintaining the deficiency. Why would we ever want to do that? One of the key things that I would like everyone that's listening to know is that it was just in the 2000s that the last trial of high-dose estrogen, estradiol, was used to treat breast cancer. And the lowest dose group that they used was 6 milligrams per day. The highest, I think, was 30. Okay, so if estrogen causes cancer, then how are we treating cancer with estradiol? And even beyond that, before that, what was the last line therapy for metastatic breast cancer?
Anabolics.
Yeah.
Testosterone and anabolic steroids like Masteron that were developed, DHT derivative. Those were very effective drugs, and they cost pennies on the dollar compared to biologics. And so are those on the market here in the U.S.? Well, testosterone's on the market, but not those others.
Yeah. Yeah.
When they're the most highly effective drugs for it, then why?
Yeah.
I can think of 3 people straight off the cuff that have had breast cancer, have been treated for it, and each one of them, 2 of them were in their 50s, one of them was 21. And with that, one in particular is one of my very best friends, and she is terrified of hormone replacement therapy. Terrified because she was told, this is how she explains it to me. She was told, hormones caused my breast cancer. There is no way I'm putting that back in my body.
Oh, that's false. There's no literature to support that estradiol instigates cancer in a living human being. It's only bench work. And from that proof of concept, it's morphed into, okay, we're going to use suppressive therapy, right? Well, what happens to suppressive therapy? Well, when I say that, it's called endocrine therapy, suppressive therapy. If you use like aromatase inhibitors or SERMs like tamoxifen to suppress that activity, there's consequences to doing that because then the body adapts to that drug and it becomes less efficacious. Well, it doesn't change the survival outcomes long term. It might be for the 5-year survival, but with breast cancer patients I've talked to, even here recently, there is not a discussion between the oncologist and what their survival is without doing anything. So they don't have a litmus test. They don't have a baseline to make a judgment about when they talk about BI-RAD scores and all that. People get they don't know that terminology.
Yeah.
And so I've even asked a surgeon about it and how they do an informed consent. Well, part of the informed consent per the AMA Code of Ethics, anyone could go see it. You have to talk about the consequences of not using the therapy. And so that means what is your a life estimate at this point in time? And without that, you can't make an informed decision about, okay, should I just forego this? Should I take the suppressive therapy? And almost always across the board, they choose the suppressive therapy, often with chemotherapy, sometimes radiation therapy, the whole 9. And those in a younger woman, chemotherapy will cause a premature menopause.
Yeah, that's what
It
happened
will
to the
destroy the
21-year-old.
follicles.
That's what happened to her.
Probably a good time to pause and say this is not medical advice, and please consult your provider for anything customized for you.
There's a disclaimer.
Oh my gosh.
Well, my point with mentioning that estradiol has been used to treat breast cancer is, okay, then that should be a clue that we shouldn't be scared of estradiol.
I would like you to go back and discuss what you said earlier because I think there's going to be non-medical people that hear this and go, "What does he mean by that?"
Yeah.
Go back and tell me about what you meant by they're maintaining a deficiency with topical. Say that again.
Well, if you're using a transdermal form and you're maintaining levels right at 50 or
Which
less.
is cream, right?
It could be cream.
Patches.
It could be a
Gel,
patch.
could be a patch. Okay.
It could be any of that. But if you're maintaining that deficiency, what health benefit are they getting from the treatment?
Right.
They're not.
Well, I think what happens with that though is okay. So you have menopause. Somebody does. Female.
Oh, yeah.
Not you specifically. You.
Well,
Sorry, Mandy.
yeah.
And you show up to your OBGYN and you go, "Hey, I've got hot flashes. I'm having night sweats and I want to stab my husband and I don't sleep well. All the things I hear every day in my clinic, but hot flashes." And you get a topical estradiol. It is capable of stopping the hot flashes.
Right.
It has enough oomph. Like some drugs do really well absorb through the skin and some don't. Okay. Progesterone's a great example of absolutely not through the skin. For those of you who are taking topical progesterone, hear me now. It's worthless. You could treat vasomotor symptoms. You could treat the night sweats with topical. But are you really getting all the other secondary benefits that we really want? bone turnover. So we have improved bone densities, reduced plaque scores, reduced tau plaquing for dementias. Do you get those with topical? Probably not, unless you're bathing in it like multiple times per day.
Right.
Okay. So you could get there, but you're still maintaining the deficiency because it's not truly breaching the threshold of where we know good things happen.
Right.
So how would someone know if they're using topical? Let's say, how would they know that they're not receiving the benefits, that their levels aren't where they're supposed to be?
Well, I don't know if you've heard of this company called Optimize You, but you should go to a place like Optimize You. You should go to a place that has people that are educated enough about the topic to ascertain your levels and help guide you through this process of keeping them therapeutic. Yeah. You can't just never check labs on a person, give them some topical estradiol and go, well, you're fixed. You've got to see the levels they're attaining and what they're sustaining to say that you're giving them adequate therapy.
But wait, one of the guidelines that was just retired, they don't even
Recommend checking
levels.
Yeah.
If the woman has 12 months since the last menstrual period, they don't even test estradiol.
It's the craziest thing to me with that. I mean, so I'm going to rip the gas gauge out of my car, and I'm just going to put some gas in wherever I feel like it.
Take a chance.
And I'm going to take a road trip, and I'm going, there's gas in it, I guess. Right? Like, what is that?
Well, it's ridiculous. Now, if you look at the male guidelines, and this is why I like to compare males to females, because we've been forward thinking with men's health, but we haven't with women. It's been the dungeon. But in men, they recommend labs, other measures to look at, even measure the gonadotropins to see what type of hypogonadism is there. Wouldn't the same thing, shouldn't it be applied to women?
Right.
Shouldn't they have labs to
So-
check the hormones?
Josh, maybe you can answer this too. You guys all see patients to some degree, but if I am coming in and I have hot flashes and I got a topical estradiol and I'm like, I don't have those anymore, I'm good. How could I, as a patient, walk into any practitioner and say, can you test this for me? How do I say that and not seem like, how do I say that in a way that's not like, well, I've been WebMDing this bad boy.
I think the what we're all talking about is you've got symptom relief and you've got preventative care.
Okay.
Right.
Which are two different things.
Which are two. Symptom relief, to Jerry's point, you can get symptom relief with transdermal at what we would describe as a deficient level. Not for it's efficient for or sufficient for the symptoms, but it's inefficient from a standpoint of prevention.
Okay.
Heart, brain, bone, right? And so I think the first thing I would tell a patient is they actually need to know that, because they,
and that they don't know.
Right. They don't know that. And
No.
I think that's changing. We'll get to the FDA, even their write-up recently when they removed that.
Well, what's the biggest health issues that women face? If you look at the CDC, okay, what is the number one killer of both men and women?
Cardiovascular disease.
Cardiovascular disease. Where is breast cancer in that chain? It's down, several factors down.
All cancers combined is still below.
Right.
Yeah.
Just to be specific. Yeah.
So number one, don't we want to prevent cardiovascular disease? Now we know that the closer to menopause, 12 months since the last menstrual period, the closer that we initiate treatment, the longer the health benefit. And if we wait too long, 10 years out, and really, if it starts going past 6 years, they're really losing sensitivity. There's pathophysiology it's developing that we can't reverse. So the closer we get them on therapy, sometimes even in perimenopause, it's more beneficial to them long term for health outcomes.
Well, the sad part is, if you lined up 100 providers, I bet you it's the minority of them that would be able to recite the fact that estradiol plays a role in cardiovascular risk modulation to start with. Like, they would not associate that right out of the gate, probably, if they're not educated in hormones. Back to your question about, okay, how do we get someone to check these if you're just a random patient that walks in a clinic that maybe isn't an Optimize You, okay? I think a problem would be, what are we drawing? So, okay, so you're going to check estrogen. Well, the problem with that is quite often maybe you have a provider that's just not really familiar with hormones and they just check a total estrogen burden. You get some information out of that, but you're getting also the other metabolites that are there from maybe your adrenal production or like you're getting estriols, you're getting estrones, you need to know your estradiol level.
Right.
Okay. Like,
That's the
I
word
don't
we're looking
care
for.
about all the other estrogens at that moment. I may care about them later, maybe not. I care about estradiol. So to answer your question, I think you walk in and say, I would like to know my estradiol, my progesterone, and my free and total testosterone levels, and start there. That's a great start.
Talk to me a little bit. Twofold question. The first one is, again, not medical advice, but where would you say the data shows that level needs to be for the prevention with estradiol? Second question is, when you're referring to labs, you're talking about serum labs, right? Blood draws.
Typically.
Help the patient who, says, well, I was told I should get a Dutch test.
Oh, no. I knew you were going to do that to me today.
That's right. So
What is a Dutch test?
It's dried urine testing.
Dried urine?
Yeah.
Yes.
And it's all the face, but
I mean, I know Scott's probably making a bad face about this. I'll start it and then I'll let him finish it.
His face looks fine.
No.
So I think that most of the time Dutch test is not necessary. Let's start there. You can get really deep into the weeds with a Dutch test about various metabolite change and why
Pathways,
these genetics are different than we're kind of like bio individual snowflakes is probably a good word. I don't need a Dutch test to tell me what your estradiol is. In fact, I don't want it. Dutch test is probably in the order of, I'm guessing, $300, $400, $500 bucks. And I'm just not sure the information that comes from it helps me as much as a cheap estradiol serum level. Now, some women have gone places, I'm not going to name names, that use saliva testing. And I'll let Scott get nerdy about the numbers, but I would just tell you that if it's not cortisol, because I think saliva cortisol is the most accurate way to test cortisol multiple times per day, J-curve loops and all that. Serum is the best representation of the sex hormones that we have, not saliva. So don't go pay $500 to get your saliva tested for your testosterone because it's not as good as the blood test.
Yeah.
So I think probably some of this information, if someone were to come in and say that, has come from a 30 to 15 second reel off of social media where they've said, oh, this is the greatest, avenue to check whatever from whoever, eat beets and open your blood pathways. But, stuff like that, just random stuff that comes off of social media. And you're like, because I can't tell you how many times my friends call me and go, do you do this? And I'm like, where did you get that? A 30-second reel off social media. So if you could give anybody any advice around some of that, because that's, what do people do?
Yeah.
And that wide world of the wide web gives all kinds of crazy information. So if you guys could give any information around that in terms of like the Dutch testing or the saliva testing or anything else that involves this particular subject matter, what would that be?
Well, I think what's consistent is the thresholds that have been identified for the optimal concentrations for bone mineral density, all the metrics that we look at in women. That's been well established. And I've documented these even from the late 60s into the 80s onward. And one of the recent papers that summarized this was Glenn, 2024. And the range, optimal range that they identify in that piece, which is consistent with all the other literature I've looked at, is between 70 to 150 picograms per milliliter.
Ooh, that sounds high because it'll flag high on the labs. Is that a dangerous number, Scott?
Well, if you look, a normally cycling woman has a menstrual cycle, reproductive age years, on average, moves past 500 picograms per milliliter each month with exposure to estradiol.
Yeah, it's not uncommon for me to see labs in the 250, 300s, 400s.
Well, even if you look at ovulation induction studies where they're given like 6-8 milligrams estradiol a day, they're in the thousands. Their reproductive age. Wouldn't we be causing breast cancer in those women doing the ovulation induction? No, we don't. And so their levels are in the thousands. I've seen it over 3,000. I've seen actually some pretty high with doses higher than that. And so for us to just meet that criteria between 70 to 150, what's been demonstrated in literature, is not that hard. But if you look back to what the paradigm was just recently, and it all fell apart, which is good, I believe. There's still people that are in the box that won't think outside of that. And I have a higher critique of guidelines than a lot of people have. And I think it's the people that author guidelines, those individuals, should know how to interpret statistics.
It's good.
So they should have saw in the beginning that there's a problem with this, and there should have been a large debate instead of what happened.
Right.
And so everybody just co-signed on it, and I think that pushed women's health back into the dark ages, really. For a short period.
So let me ask you this. Jerry mentioned saliva cortisol. I would agree. Is there ever a time you would say do a Dutch test, do a saliva estradiol, just in general, and why not? I know your answer, but I just want you to tell people.
Well, for me, it's in the literature on treatment, it's serum testing across the board.
Right, the gold standard.
The gold standard.
Yeah.
That's what it is. And, we use the highest quality, or I do, to guide anything I develop with the CME, anything. It's the highest quality literature that's there. Why aren't we using that evidence the way it should be? And to me, that's serum testing. If you're not getting serum testing, do you really know what your levels are?
That's right.
Because there's error margins in each different methodology. I prefer serum.
Yeah.
I think people listen to this and they're going to go, these guys are extremists. They only want this. They hate every guideline that comes out. They're anti-establishment for, the system. No, we're not. Like, hear this and be very clear. We want to stand on the evidence, but we want to make sure the evidence is good data, right? Like, you can't, we'll keep this PC. I won't say what I was going to say. I'll take that back. You can't take bad data in. It's garbage in, garbage out, right? So you need to interpret the data. You need to understand the evidence, and you need to treat accordingly. What Scott said is absolutely true. Serum levels is still the gold standard.
Yeah.
Now, I would be silly if I didn't say somewhere down the road, if some evidence comes out that says Dutch testing is relevant for this subset of population of patients, when you find this, use a Dutch test, I will absolutely happily evolve with that. Yeah. If we didn't evolve with the literature, we'd be still like lobotomizing people and giving them mercury because they're crazy.
That's exactly what
so we have to evolve with the literature, but currently the literature doesn't support Dutch testing.
That's right.
Sorry.
No, I think it's good. And I think to your point, Jerry, we live in this system, right? We this is home for us. And so for us, it's not as much of, this system is terrible as much as we want to see it better, right? And so calling that standard up and saying there's a better way, it's not to say that, we disapprove, but it is to say, no, this matters to us because this is our reputation. This is our careers. This is what we give our life to. And so we're going to call these things out when it's appropriate.
Yep.
Yes. It makes me angry, if you want me to be real honest.
It should make you angry.
It makes me angry for myself, my daughter, my granddaughters, my mom, my sisters, but it also makes me angry for those practitioners who feel like they're doing the best work that they can for the people that they're taking care of. It makes me angry for them to go, okay, hold on. Now, because, we live in a life where we're going 90 to nothing all the time. And we're trying to do the best we can with what we have in front of us. So if they are being presented with this information and told that it's the best that they could possibly do because they're not experts at it, it makes me angry for them.
Mm-hmm.
Well, again, back to leaning on the data, I can't tell you how many providers I know that have come to us and said, some of them tongue in cheek, they'll bring me a study and they'll be like, hey, look at this. Hormones are bad. Look at this one I found. And a lot of times it's like a look back study. And for those of you, again, non-medical people here, you could do a study that's like a database search. And you'd say, okay, Google, Medicare, Google, whatever that is. Show me anyone that ever took estradiol that had a cancer. Show me that. And there'd be a number, right? There's a correlate there. It's a correlate. It'd be like saying, and I'll Neil Rousier this a bit. Hey, Neil. It would be like saying, everybody came into my house, we hung out at my pool, and we drank margaritas, and we got sunburn. So margaritas cause sunburn. That's a correlate, not a cause. And so lots of providers will yank out 10 studies off Google, off PubMed, and go, see, hormones are bad. That's a correlate. This is a correlate. It's not a cause. You have to understand from a fundamental level, how was the study set up? How do I interpret that? And was the data good or not? Yeah. And then we can make some decisions. I know I'm beating a dead horse here, but that's for non-medical, layman people, You have to understand that. Just not because you Google it on ChatGPT doesn't mean it's right, guys.
Well, there's some consequences. Look at men's health. The vegan study that was published that actually when all these people got bent out of shape because the evidence wasn't high quality, they eventually found that there were women in that male-only veteran study. But yet, has it been retracted from JAMA? But well, what was the consequence to men's health for a secondary data analysis of insurance claims? That placed the box warning on testosterone that just finally came off.
Right.
And it wasted not taxpayer dollars, but it wasted millions of dollars to run the Traverse trial.
Right.
Over a secondary data analysis that should never have been used by the FDA to actually put that box warning on because it didn't even follow their tier of evidence. Highest quality evidence, high quality meta-analysis. But even now, are randomized controlled trials because even the meta-analyses can be biased.
Well, when I've talked to Dr. Morgenthaler about this, he's practiced for a long time, and he mentioned he asked this question one time in this cohort. He said, "Do you know how many times before 2007 that I mentioned the potential risk factor of cardiovascular disease with testosterone?" 0. He said it was not until 2012, 2013, and all of a sudden he's like, and I've been practicing doing this for 20 years at this point, 25 years, and all of a sudden this kind of comes up, right? And to your point, that where did we get that information? It was from an observation study, a correlation, right, with bad data.
Margaritas and sunburn.
That's right.
And so that's why
I'm willing to try it.
It's really important now for everyone to gauge the credibility of their information.
Yeah.
Just because of that. If you don't know how to interpret research, still judge the credibility.
Yeah.
Find a way. Talk to somebody.
That's right.
That's more informed.
Come to an Optimize You.
So let's close this out on a high note. Let's talk about some things that have happened in the past year, specifically around the FDA removal of the black box warning as it pertains to hormone therapy. So let's talk about what that means and what we are hopeful for moving forward.
Well, the risks that were previously in the package inserts, a lot of those are revised now. One of the points that I really like is the recommendation for the lowest dose for the shortest period of time. That's axed from that conversation in the package insert. I think it was a very important thing to do because even with the therapies like we were talking about, we really only get the serum concentrations in optimal range consistently with oral estradiol therapy, not transdermal. I haven't been able to see it a time on a transdermal cream or anything like that where it's maintained.
Does that not drive you more crazy than almost anything else? I mean, how many times do you see a patient and they came in, they've been somewhere else on estrogen for a year or two, and they're like, well, yeah, my doctor told me to get off this stuff because I've been on too long. And I'm like, okay, so you took this thing, you got better. Now that we're better, we got to stop it so we can get worse again.
Right.
Really? Like, what other area of medicine is that happening besides maybe like antibiotics? Okay, fair.
Right.
But what are you talking about? So, okay, so you gave me insulin and you knocked my sugar down because I'm a diabetic. And now that my sugar's normal, I'm going to stop my insulin and let my sugar get high again before I fix it again. It's crazy.
Yeah,
what
it's
are we
crazy.
talking about?
Yeah.
Lose the benefits.
And I think that's what, to your point, the lowest dose for the shortest amount of time. To me, we've been talking a lot about symptoms, but I think one of the things that I was most encouraged about from the FDA brief was on the fact that they were actually highlighting, hey, this is helpful for quality of life and prevention, right? Not just symptoms.
100%.
That there is a place for you to have a conversation with your provider about continuation of hormone therapy, even if you feel good, for that purpose of what it's doing for bone health, heart health, brain health.
Exactly. Well, part of one of the things with some of the guidelines was about not using estradiol to prevent osteoporosis or to treat it.
You're right.
It's only been used to prevent it.
Yeah.
And so estradiol is the most potent regulator of bone cells, osteoblasts and osteoclasts.
On doxycycline depository studies, there is no other drug on the planet that I know of, and I've looked, that equal estradiol.
100%.
Period.
Yeah.
Don't have one.
Yeah. Outside of the creation of maybe penicillin, hormone therapy is one of the biggest improvements of modern medicine. I think is a fair assessment.
I firmly believe
Yeah,
that.
yeah. Gentlemen, thank you for
Isn't this
an
awesome?
hour.
Can we do this again?
On, absolutely.
I want to do this again.
Yeah.
Yes.
Good stuff.
Yeah, we're this is the heart of what we do, is to talk about tough topics that people need to hear. Again, not to be divisive, but just to give the audience a place where it's like, oh my gosh, like you guys are actually talking about the things that I'm trying to navigate, right? And it's heady, a lot of depth, a lot of education, but it's also about being practical. What can somebody do from this and make a difference in their life?
You should water this. Sorry, go ahead, Scott.
Well, I think overall, the goal in my mind with Optimize You is to stay at the tip of the spear and
Good.
use the highest quality evidence to guide treatment. When the guidelines fail, that's where we go.
That's right.
We stay there.
Here's the easy path for everybody that listens to this podcast that has a question about how to do this. You just find a clinic like this. Could be an Optimize You. Could be any clinic. And go get your levels checked and have the conversation with a provider that can actually have the conversation with you. That's step one. And then you can proceed from there. That's how you do this.
That's great. We'll end on that, Jerry, because I don't have a better way to close it. That's great.
Love it.
Thanks, boys.
Thanks, everyone.
Good.